So, this is the topic of my talk. Is there still a rule for auto transplant? يعني مش تعطوني شيء سهل يعني BTK the rule of BTK mantle cell lymphoma ولا bispecific ولا شيء زي كذا. This is an ongoing debate since more than 20 years وأنا المسكين نحل لكم إياها. فنشوف. بسم الله الرحمن الرحيم. So, first of all, maybe some introduction about mantle cell lymphoma. And I understand here not only experts are sitting, but some trainees who want to learn something. So mantle cell lymphoma is accounting for 6% of all non-Hodgkin lymphoma, and I believe in Saudi Arabia this is not different. We have probably 40 to 50 cases, new cases per year in Saudi Arabia. Mantle cell lymphoma is more common in men, also 4 to 1, around 70 to 80% of cases are men. And the median age at diagnosis is 60 to 70. And mantle cell lymphoma has a leukemic presentation in up to 20 to 30% of the cases. And most of the cases to have advanced stages, which means if you have a referral, mantle cell lymphoma with a report stage 1 and 2, you have always to question mark this. You have to do all needed tests in order to prove or to exclude that the patient has an advanced stage, PET scan, endoscopy, whatever. So the driver for the development of mantle cell lymphoma relies in the translocation 11, 14, 11, the CCND1 gene is located in chromosome 11, which is encoding for the cyclin D1, and we know cyclin D1 is promoting the cell proliferation. It's usually inactive. On chromosome 14, it's encoding for the EG light change, and we know that there is hypermutation in order to produce many antibody-directed against thousands and thousands of epitopes. And if the CCD1 gene translocated nearby the heavy chain gene, it will be automatically activated, and the overexpression of cyclin D1 will take place, and this will promote the B cell activation, leading to malignancy of this specific clone. Mantle cell lymphoma is divided to classical mantle cell lymphoma or leukemic, which is usually non-nodal mantle cell lymphoma. Again, this is not very frequent, around 20 to 30% of the cases, and usually in many cases you don't need to treat these patients. This is in the opposite and contrary to other lymphomas. Diffuse large B-cell lymphoma, as example, if you find malignant cells in peripheral blood, you have to treat. So in mantle cell lymphoma, you don't need necessarily to treat this patient. Don't panic. And we have also the blastoid variant of mantle cell lymphoma, which is an aggressive form and requires treatment always. We are categorizing mantle cell lymphoma in high risk and low risk according to these parameter. Low risk Ki67 less than 10%, high risk more than 10%, SOX11 negative, blastoid 611 positive, and so on. And just for completion, we have the MEPI score, we have the FLIPI in follicular lymphoma, the IPI in Hodgkin, and MEPI was developed. Why? Because it's important for anticipation, how long the patient will survive, how the patient will do with any treatment. You can see that patient with low MEPI, they have a better outcome than those with high MEPI score. But in fact, as in follicular lymphoma, we don't need to treat all newly diagnosed patients with follicular lymphoma. Specific Those patients with not blastoid morphology, normal LDH, low Ki67, and so on. So, as not all mantle cell lymphoma needed to be treated. Over the past years, decades, it has started, there was different advancement and approvals in mantle cell lymphoma management. Has started with the approval, as Mubarak mentioned, for tuximab in 22, and thereafter we have the MCL network study, autologous stem cell transplantation, Nordic. Then we have the era of PTKs, Broxycell, and lately pirtobrutinib, which has been approved in mantle cell lymphoma. We'll go to that one by one. But we learned here in mantle cell lymphoma that we have to differentiate between fit patient and unfit patient, those who are eligible for those intensive chemotherapy and those who are not fit for that. And this is important when we have an EU patients. But one by one. This slide I like the most. If we look to the left side, this cartoon by eras and treatment. And هنا سأصمت قليلا. Why? Anyone knows why? Anyone who wants to answer the question whether autologous stem cell transplantation has a major role in the management of mantle cell lymphoma? Anyone noticed anything? Look here. So, mantle cell lymphoma was investigated, well, has been investigated since 1996. You can see, look after 8 years. Mantle cell lymphoma followed by CHOP. And this is reflected the overall survival, by the way. The overall survival of the patient is in the range of 30%. Tamam? Then we have R-CHOP introduced. With auto-transplant, as a changing from CHOP to R-CHOP, but with auto-transplant. The overall survival improved to near 60%. Tamam? Then we have the addition of RDEHA. R-CHOP, RDEHA, and auto-transplant is still there. Overall survival was improved to 70%. And now we are in the era of PTK. With auto and without auto, the outcome, the overall survival has improved to above 80%. What does this tell us? مين يعرف? It is not only the auto transplant which is improving the overall survival, it's probably the induction, it's probably the treatment what we choose prior to auto transplant. And this is actually the answer of my talk. I can stop here, but let us go one by one. هذه الستدي اللي everything has started with it for auto transplant, and then after people they consider auto transplant as standard of care. So this is the MCL network study where patients were treated with CHOP 6 cycles. Thereafter, they reached partial remission or complete remission. The patient were randomized to 2 additional CHOP, and I think the older from us, they know that earlier we treated our patient with 8 cycles, not 6 cycles. As 2 cycles followed by interferon maintenance. And the other arm, the patients were consolidated with autologous stem cell transplantation. Tamam? And this is the data what were published in Blood in 2005. Auto transplant showed a better PFS than interferon. Everyone jumped on that. Auto transplant is now standard of care in mantle cell lymphoma in eligible patients. But the study was conducted, it has started 1996, and CHOP, rituximab was not approved yet. And many of the patients who were included in the study, they were treated with CHOP. The rituximab approval came later on in 2002, and the study was amended, and rituximab was added, but it was added just to 26% of the patients. If you look to the PFS of patients, the 61% of the patients who received CHOP, auto versus no auto, there was no significant difference, which means the main driver for the benefit was, by the end, rituximab. Again, we are coming back to the previous curves with better induction, better outcome, not the transplant. طيب, I have to be fair as well and looked after real world data. And the real world data from the same group, the Nordic group, they look to their data, and most of the patients, they received the Nordic regimen as a dose-intense chemotherapy, 97%. And you compare those who received auto versus who did not receive auto. Majority did not receive auto. And you can see here, there is even an overall survival benefit according to these retrospective data. But I know, and everyone from us know, who transplanted mantle cell lymphoma, even after 10 or 15 years of transplant, patients are relapsing. Auto transplant in mantle cell lymphoma is not acknowledged as a curative option. So at that time, I said the data were published in 2005, and the paper which showed that there is no benefit between CHOP and auto transplant arm, it was published 2021. And between 2005 and 2001, everyone who was conducting clinical trials with the younger patient, he used the auto transplant as this is the case. Used the auto transplant as a standard of care, and this is the MCL younger study, which is a respected study. It compared basically two different regimens, 6-R-CHOP or 6-R-CHOP plus DHAP, and they found that the cytarabine-containing regimen is the one which is the best, as that was taken as standard of care, R-CHOP, R-DHAP, followed by auto transplant. And thereafter, we have the Lima or the LISA study, where they established rituximab maintenance for 3 years after autologous stem cell transplantation, of course, after R-CHOP and R-DHAP, leading not only to PFS, but only to OS. And this is probably the only study, to my knowledge, where maintenance rituximab in lymphoma showed an overall survival benefit. Really a good and straightforward study if you want to offer pure patient auto transplant. The follow-up data confirming and maintaining benefit of auto transplant and rituximab maintenance in terms of PFS and OS. But wait a little bit. They used R-CHOP in both arms, in the LISA study and in the the MCL younger study. We know that this is trivial, I think. Why are using R-CHOP? We know that R-CHOP in mantle cell lymphoma is inferior to bendamustine. And this we know from the STEEL trial and the BRIGHT trial. So it has to be here question marked. Bendamustine was studied against cytarabine-based regimen in this study, S1106 study. Despite premature termination of this study, I think some hint and some information we could win. There was no difference in PFS and OS between BR, as a bendamustine rituximab as induction, and the intensive chemotherapy regimen containing cytarabine. So the British Columbia looked as well to their data. Patients who received R-CHOP, R-DHAP as an intensive chemotherapy followed by autotransplant were retrospectively compared, as from the younger trial, were retrospectively compared with their own data, and patients who received rituximab plus bendamustine followed by autotransplant, and there was no benefit from dose intensification if you go for autotransplant. No PFS, no overall survival benefit. This cartoon is from the US, looking at the change in pattern in first line, the trends, what physicians are doing. And you can see here that we are moving away slowly from cytarabine from around here 30-40% to probably here a little bit more than 25%. But we are in younger patients. I'm not speaking about older patients here. In younger patients, we are using more and more bendamustine and rituximab, acknowledging now that BR is a better partner in such cases. Now we are coming to this study, which is actually answering some of the questions. The triangle study, I will go very quick. All of us, we know the triangle study, a 3-arm study in patients younger than 65. Standard of care at that time versus standard of care plus ibrutinib versus R-CHOP alternating with R-DHAP with ibrutinib followed by autotransplant and rituximab and ibrutinib maintenance. I will go through very quick through the study. So you can see here, Reyad Dada, autotransplant failed to show superiority over ibrutinib alone. And auto plus ibrutinib failed to show failure-free survival superiority over ibrutinib alone. In fact, there was a superiority of ibrutinib over autotransplant in terms of FFS and in terms of overall survival. The arm of the ibrutinib has a better overall survival than the arm of autotransplant.
3 minutes, Prof.
Inshallah, بنحاول نعجل. This is to answer the question, do we need autotransplant? No. What is this? Autotransplant has high-risk patients. Yeah, subgroup of patients might benefit according to the triangle data from autotransplant, especially those who have a KI 67, 50 and more. Autotransplant is not a best option. It is individualized decision, I think, because of the high toxicity. And we are coming now to this interesting study, and this is probably will give everyone the information he or she needs. The patient up to 70 were treated with treatment, with physician of choice treatment, any treatment. Then the patient had MRD tested. If the MRD is negative, the patient, and about 80% of the patients, they were MRD negative. This is very important information. If they are in complete remission, they are randomized to auto plus transplant plus rituximab or rituximab maintenance. MRD positive, auto transplant. These are the patient characteristics, and most of the patients received intensive regimens. And this is showing that MRD patients, MRD negative or UMRD, undetected MRD, there was no benefit of autotransplant addition in MRD negative patients. And OS also, there was no OS benefit. So with that, the study concluded that MCL patient in first complete remission with undetected MRD did not benefit from consolidative auto. Some of the patients who have an MRD positive disease and went for transplant, they benefit in terms of PFS and OS. But how much is it? Just 3%. That's why I think it has to be individualized. Looking to the NCC guidelines, if patients reach complete remission, undetected MRD, maintenance rituximab, no autotransplant, based on the study before, if the patient has MRD positive, consider autologous stem cell transplantation. And please keep in mind, the benefit according to the study, the ACOG study, was just 3%. So I will jump very quick through the last slides because the time is over. We have new novel agents, which I think will displace the autotransplant, like this combination, zanubrutinib with Arduhax, where some patients receive auto, but I can tell you here in this study, just five patients received transplant. And despite that, the overall survival in 2 years was 100%. So an era for improvement is here. We don't know what to do with these patients, the P53 patients. They have a less favorable outcome with even with dose intensification of chemo, with high dose chemotherapy and transplantation. They don't benefit necessarily from that. And it has been investigated here in the Zimbabwe trial, TP53 patients were included, and you can see this combination might be the magic for such bad risk patients. Zanubrutinib venetoclax delivers excellent outcome in all subgroups, regardless of TP53 mutated or not. We have also glofitamab, which interesting complete and overall response rate. We have bolatuzumab with mosunetuzumab with an overall response rate of 75% and complete remission of 70%. And we have Brixocell data already approved in Mantle Cell Lymphoma. We have also Liso-cel data with encouraging overall response rate of 83% and complete remission rate of 72%. And if you look to the MCL network charter for the upcoming studies, you can see here in first line, they are still offering autotransplant, but they are offering also upfront CART with no transplant. So with that, I would like to conclude. The triangle study showed that autotransplant is not superior to ibrutinib without a transplant. Currently, there is no decision whether autotransplant has benefit to ibrutinib, but for certain, there is more toxicity with the addition of autotransplant. Patients with high-risk Ki-67 may benefit from adding of CART, but take care, the number of patients included in both arms was 47, 46, as not too many patients. The ER4151 study showed that MRD negative complete remission patients do not benefit from autotransplant, and these numbers are 80% of all patients included. MRD positive patient after induction may benefit from autotransplant, but the magnitude of benefit was just 3%. That has to be taken in account. Patients with TP53 do not benefit from intensification, and novel agents might be the gap. And I think with the advent of higher effective novel agent, CAR, bispecific, PTKs, I think these are challenging the autotransplant, and autotransplant hopefully will diminish too. Thank you very much.